Tim says, I'm kind of tasked to look at some treatments for airway disease in racehorses to kind of follow on from Scott's talk and think about or how we treat them or how we could treat them, and also really to think about what's the evidence for each of the treatments. That's really kind of what we're about, and in the Thoroughbred Health Network we're trying to kind of make the evidence that's out there much easier for folk to understand and to take on board, etc. So what are our options, treatment options given Scott's talk, and how useful are these treatment options? So what I've tried to do is split them up into the kind of three things that we try to do on the network there. What we've got good evidence for, what we kind of really know there's fairly strong evidence that these things really work. What we've got moderate evidence for, that it's either it does work or it doesn't work, or it might work, we're not really sure. And then finally, what do we have minimal evidence for or require an awful lot more information on? What are the things, what are the real big gaps there that have probably been there for a long time and we still haven't actually got round to looking at for various reasons? It's important to say I'm not really going to tell you exactly how to treat your cases of IED. I'm not here to tell you, what you what to do or your vets what to do, etc. There's a whole lot of different factors. When you're dealing with an individual horse, there's a whole lot of different factors that are going to come into play. So there's the actual diagnosis. As Scott says, it can be really hard to get the diagnosis in some situations. Are bacteria involved, are bacteria not involved, etc. Is it the severe form of asthma, or is it a much milder form like an IED type of case? So the diagnosis is obviously going to be very important, the severity of the disease. Cost of treatments is going to come into play as well. With many cases, economics are important. The practicalities of using some of these treatments as well can be really important. Handler compliance, patient compliance as well. Some horses won't take oral drugs, for example. Some of them won't tolerate some of the things that we put on them to try and deliver medications, for example, as well. But the most important thing we're going to talk about today really is the efficacy in treating that condition. So something else that we want to think about. And this is something we kind of use now in veterinary medicine. They use it in medicine as well, evidence-based veterinary medicine we call it. We kind of think about this pyramid of evidence that we have of how good we think the evidence for a particular thing is, and they talk about this pyramid with being higher up in the pyramid being better evidence. So you can start with expert opinion. Obviously that's very valid information. Expert opinion it's kind of decreed as the kind of the bottom level of things, but as you go up that tree you kind of get more and more kind of strong evidence, if you like, that theory that you have about a particular product, maybe a particular drug is actually good information, whether it's bad information or it says it doesn't work or it says it does work. And that information can be either unfiltered information or it can be filtered information. And what we try to do for our ease of putting these things out on the Thoroughbred Health Network is to use that filtered information, to use information from experts. So experts have looked at a lot of the information, gathered together all the data, looked at all the different studies and said, well, yeah, on the basis of probabilities, we think these things are good and we think these things are bad. So that's kind of what we're about, trying to use that kind of pyramid of evidence, if you like. So we're very lucky if there are these what we call consensus statements. This is one that we have for IED that came out relatively recently in 2016, which basically summarizes all the information on these particular types of problems. And it can be focused on treatment, it can be focused on the pathophysiology, all sorts of different things. But this one is a consensus statement on inflammatory airway disease in horses, and by a variety of different people who would be deemed experts in the field. And quite disappointingly, perhaps, the scientific, one of the conclusions, the scientific evidence concerning the management of horses with IED is sparse, and therapeutic options are mainly based on clinical experience. So a lot of those kind of low-level things, if you like, and study results obtained in REO horses. So they're at the more severe end of the scale, those kind of more severe asthma types of cases. And the reason for that is probably because they're easier to study. It's easier to define that population, so it's much easier to study them. You can get 6 of those horses, we can do them and put them in an experimental study and look at the treatments that work with those cases and the treatments that don't work with those cases, etc. So that's kind of disappointing, but it just emphasises the point that we need to do more and more to kind of look at the treatments for inflammatory airway disease. Kind of put down here a very sort of simple scheme of our potential options, if you like, for IED treatment, and we'll kind of go through each of these. Just going clockwise just now around these, there's modifying the environment. That's a really important thing, as we'll come to see. Anti-inflammatory drugs. drugs that can dissolve mucus. We talked about mucus being important potentially, or certainly a significant thing that can tell us we have disease. Can we dissolve that mucus? Does dissolving that mucus help resolve the disease? Can we stimulate the immune system if that's important in trying to resolve the disease? Do antibiotics help? Are bacteria involved? Do antibiotics therefore help this the treatment of this problem as well? And then opening up the airways as well. Scott talked there about bronchoconstriction when the airways kind of clamp down, etc. That's certainly potentially a component of this disease. Therefore, if we open up the airways, does that improve our treatment of these cases? So I'm going to start with the potentially good things we have good evidence for. So we have good evidence that modifying the environment is crucial, and you can split that into two different parts. First of all, if you modify the environment, it reduces the toxin spore load, all the dust, etc. So we know there's lots of nice studies that show that if you modify the environment, you're going to make things better. Basically, you're going to reduce the toxin or spore load. There's also really good evidence, a variety of different studies, that modifying the environment improves the clinical signs of IAD with or without other treatments. So some of the studies have used other treatments as well. But whatever you do, if you improve the environment, you improve the clinical signs of these horses with inflammatory airway disease. So how do we achieve that? You kind of know all this yourselves, obviously, and Scott's gone through some of this. But we maintain horses permanently at pasture, potentially. That would be one way of doing it. Obviously, in a trading scenario, that's not going to be possible, but certainly if you can give them access to outside, that's going to be beneficial to them. Dust-free beddings, dust-free forages, changing the location of the forage if it's close to horses that are going to be potentially respiring the dust from those forage. Other management alterations, so considering things like grooming them, for example. Do you groom them outside rather than grooming them inside? Because if you groom them inside, are you creating a dusty environment for them? So there are a variety of different things you can do to try and avoid exposure to dust. As I said, there are numerous well-conducted studies that back up this approach, and particularly in, again, the severe end of the scale, the recurrent airway obstruction. But even in the IED, as Scott showed that study earlier, feeding from a haena increased exposure. If you feed from a haena, it's been shown that you have increased exposure to dust and various other things compared to feeding from the floor. So that's a good example of IED cases where that has been shown to be beneficial. And we will see improvements in lung function by changing the environment very, very quickly. In REO cases, it's been showing within 3 days you'll start to get improvements in lung function. So it's certainly something that's very worthwhile doing. There's very good evidence that that is the case. So we'll put a tick for modify environment, shall we? What about anti-inflammatory things? So Scott kind of touched upon this again earlier about the effects of inflammation. So inflammation does a variety of different things to the airway that are going to be detrimental to that animal and potentially detrimental to its performance. So as Scott said, it tickles up the airways, it makes them super sensitive. We get airway spasm because the airways clamp down. We get an increase in the mucus levels. We get recruitment of these inflammatory cells into the airways, and we potentially get, over time, with more severe types of disease, we'll get remodeling those airways as well. So they may get more scarred, for example, to use a kind of common term. They may get kind of more scarred and therefore permanently damaged long term. So these are all the things that inflammation can do. So do anti-inflammatory drugs, can we use anti-inflammatory drugs to try and abrogate that effect? Well, the options for anti-inflammatory drugs, there's a variety of different things we could talk about, but the two major options that we have are what we call the non-steroidal anti-inflammatory drugs. So these are the aspirin-like drugs that we use ourselves, but for horses we use bute, obviously. We use phenidine. There's a variety of different non-steroidal anti-inflammatory drugs we can use for horses, but there's good evidence that they have no effect in this type of problem, so we're going to just ignore those for just now. In contrast, we know that the glucocorticoids, the steroids, of which prednisolone is maybe the kind of one that's most freely available. We know that there's good evidence of an effect of corticosteroids and glucocorticoids. Oh. So what are they, or what do we know about them? There's good evidence that it causes decreased airway reactivity, decreased airway hypersensitivity. We know that it's most effective with changes to management as well, so we mentioned the changes to management. So if you do the two together, you get a much better effect. And there's the various different options. I'm not going to go through them all today, and you'll obviously chat to your vet about these sort of things, but there are several different drugs, so we can use short-acting drugs versus long-acting drugs. So prednisolone is a shorter-acting one. Dexamethasone is a slightly longer acting one, for example, and slightly more potent. There's several different modes of administration as well. So you can use oral medication, you can use intravenous medication, and you can use intramuscular if you like, or more popularly now the inhaled steroids are quite useful. So using things like this Equihaler over here on the right hand side, using one of these metered dose inhalers. So just like with asthmatics, many asthmatics will have they'll have the blue puffer and they'll have the kind of the ready puffer. The ready puffer is the steroid that they use for their asthma to try and control their asthma. In terms of inhaled versus systemic glucocorticoids, just to touch on it briefly because it's quite important. There's many proposed benefits of inhaled steroids. You're obviously delivering the drug to the right area. You're delivering it locally into the lungs. It's a good route of administration. The potential is a shorter drug withdrawal, which potentially has benefits if you're working with competition horses as well. And potentially it's going to minimise the side effects as well. There are some systemic effects from using these things by inhalation, but they tend to be much less than they are from using them systemically. What we don't, or we have very little evidence for, is the appropriate dosage for a clinical effect in inflammatory airway disease. They've been used quite a lot in RAO, and they've been used in studies with RAO to show an effect. But they've been used at a vast different array of different dosages. So we don't actually know the appropriate dose for a clinical effect, the least dose, if you like, so the cheapest dose, if you like, to have a clinical effect for you. We also know that the drug can reach its target, but we don't know how much drug actually gets to the target and how variable that is in individual horses. It's probably variable from horse to horse. So there are a lot of unanswered questions there, but this is something that's being used a lot in the nowadays. And detection times, we've got no information at all about detection times for these things, so it's quite difficult as vets when we're using these drugs to advise on detection time and withdrawal times of these drugs. So I'm going to put a tick against the anti-inflammatory drugs. What about antibiotics? So antibiotics is always the kind of the contentious area when we talk about airway disease in racing horses. As Scott says, we've got really good evidence of an association between bacteria and inflammatory airway disease, but we have this kind of chicken or egg type scenario. Which caused the other? Are the bacteria there just because we have IED, or is it the bacteria that's caused the IED? And it's probably it's probably different in some populations compared to other populations, in some horses compared to other horses. In terms of treatment with antibacterials, we've got very few studies on the treatment of inflammatory airway disease with antibiotics. There's one or two. This is one that's often cited. So this is from Newmarket. In fact, Tim's on that paper. Did you know you're on that paper? So it's lower respiratory tract disease in thoroughbred racehorses, analysis of endoscopic data from a UK training yard. So this study showed a resolution in signs of IED in about 70% of 2-year-olds, 86% of 3-year-olds, and 100% of 4-year-olds, based on a kind of management regime where they kind of Stella probably knows a bit more than I do, because she works in the practice that does this, but basically they'll go into the yard, they'll kind of take lots of track washes, etc. They'll come back, they'll assess the results, and then they'll use antibacterials for treating those things on the yard. And they showed, as I say, these results. The key thing about this was there was no control population, so there were a lot of other things they probably did. So time was a factor here. We don't, all these horses obviously had more time before they kind of looked at the results of their treatment. There would be other things that they did as well at the same time. So because there's no control population, you can't say that those antibacterials were the cause of the improvement in these horses. They may have been a factor, but you can't say for sure. And they admit that themselves in the paper as well. There's a clear need for evidence-based analysis of treatment regimes to assist clinicians in decision making when managing disease in both individual and group situations, because we all face this type of problem. Do we want to use antibiotics, or do we not want to use antibiotics in these inflammatory airway disease cases, and which ones do we want to use them in and which ones do we not need to use them in? Here's another one as well, which again was unfortunately not controlled. The primary aim of this study was actually to look at inhaled versus systemic antibiotics and how they compared. But again, we had 16 cases of IED in both groups, whether it was inhaled or systemic amikacin, which is an antibiotic. Both groups had reduced clinical signs and reduced bacterial isolation after the period of treatment. So less inflammatory cells in the horses treated with inhaled antibiotics, interestingly, compared to the systemic. But both showed an improvement of there again. But again, no control population. So you can't say for sure that it was only the antibacterials that were causing that improvement. So to kind of summarise there, we've got good evidence of an association between bacteria and IED. We know that when used as part of a treatment regimen, the horse improves, but there are no controlled studies. So no studies have shown that they're effective on their own merit, and we need much more information on that, and we kind of need to do the work on that. If required, which antibiotic is better or best? We don't really know the answer to that. We tend to what we'll tend to do in most situations is we'll base it on the level of neutrophils in the tracheal wash. We'll also base it on whether we get a culture of bacteria there, and based on that culture we'll look at which antibacterials the bacteria are potentially sensitive to. But there's lots of unanswered questions there, and which is, you know, what is the best duration of antibiotic use? Again, we don't really know how long we need to use these antibiotics to cause a cure with these types of situations. So lots of unanswered questions there, and more work that needs to be done. We do know quite a lot about antibiotic delivery, and there are a variety of studies suggesting that inhalation is superior to intravenous or systemic administration for accessing lung fluid. So there are nice studies on a variety of different antibiotics showing that. I've picked out two here. So this is using a drug called gentamicin, either intravenously into the vein or by aerosol. And this study very nicely showed that if you're using the aerosol, you're going to get lots more antibacterial into the bronchoalveolar lavage fluid, so this lung fluid that Scott was talking about earlier, compared to the intravenous administration. So if you use it intravenously, you're not getting as much into the place where you potentially want it to be, basically. And similarly, a different study using a different antibacterial called marbofloxacin, which you could argue we shouldn't be using, but I won't go into that just now. But again, it's demonstrated the data in a slightly different way there, but you can see intravenous versus aerosol administration of the marbofloxacin, this bronchoalveolar lavage fluid, so the lung fluid. We're getting much higher concentrations when we're giving it by aerosol administration. So we certainly have fairly good evidence to say that inhalation is maybe superior to accessing the area that we want to access for antibacterials, if in these cases where we do want to use them. But as I say, you have to think about the ethics of such things when you're talking about drugs, particularly drugs like marbofloxacin, which would be deemed don't use them unless you really need to in human medicine. So I'm going to make a question mark there against the antibiotics. Some evidence that opening up the airways, bronchodilation, has positive benefit in IED. So there's lots of different drug examples here, but the most commonly used ones would be ventipulmin, also clenbuterol is the drug name, or salbutamol. Ventolin would be one of the kind of first products that was available was the Ventolin inhaler, and the drug name, as I say, is salbutamol. And there are longer acting versions of salbutamol as well. Their mode of action is that they dilate the airways. They possibly also improve mucus clearance, so they maybe help get rid of all that mucus up from the airways. And lots of modes of administration again with these drugs. So again, either oral, intravenous, and again, quite commonly we'll use metered dose inhalers with these drugs. Many of you have maybe used them, and there's also we can use them by nebulization as well. That's another option that we have. So what's the evidence for them? So there are, as I say, there are a few kind of pieces of evidence. Most of the evidence for these types of things would be, again, in recurrent airway obstruction, the severe cases. But there are some pieces of evidence in inflammatory airway disease. So we can see some short-term improvements. It's quite interesting with this drug. They quite often develop tolerance to this drug, actually. So the improvements that we see are only short-term. So this is quite a nice study showing. Essentially, what we've got here in this graph is improvement in airway function. This is time along the bottom there. And these are individual horses actually, but and this some improved greater than others, and hence some of them are kind of hidden down at the bottom there. But basically, we had a nice improvement in the airway function of all these horses at kind of the 14-day stage, and then that improvement in airway function tended to tail off as they developed tolerance to that. So we certainly can have some improvement in airway function with using these types of drugs, potentially in IED cases as well.
Presumably in that they were kept on the same dose the whole way through. That wasn't an indication of them being on
No, they were on the same dose right the way through, What hasn't been evaluated in IED is the efficacy of inhaled bronchodilators. There's no studies that I found anyway that told us about how good inhaled bronchodilators are. As I said earlier, there's lots of evidence of the use of them in REO, and there's a wide dose range that's been used, but there's no good evidence of their use in IED, but people do use them for it, and there's sound evidence for that because of the evidence that it's potentially beneficial in the evidence in REO. Certainly inhaled, the use by inhalation might improve drug delivery, but much more work needs to be done again in that kind of area to give us a bit more information about that. So there we are with the question. I'll put a question mark there again about opening up the airways. I think a bit more work needs to be done on that as well. There's some evidence that immune modulators may reduce the clinical signs of or inflammation in inflammatory airway disease. So these are compounds, immunomodulators, it's got a broad term. These are compounds that are either naturally produced by the body that are involved in the immune response, and we're kind of artificially giving them, or they're substances that potentially stimulate the immune system to kind of to kick into action and to have an effect. So a variety of different ones. I've kind of listed only a few there, but interferon is one that was talked about and was used for a number of years. Certainly when I was in racing practice, we used a bit of interferon. Xylexis is a one that's currently on the market, an inactivated parapox ovis virus. It was on the market sort of 20 years ago, then it went off the market, it's come back on the market again now. Fatty acids have been looked at in this respect as well, nanoparticles, and they're inflammatory cell stabilizers as well, so there's things that can kind of stop some of these inflammatory cells having the action that they do. So a number of different things that you can do. I haven't got time to go into them all, but just to kind of touch upon a couple, there's fairly decent evidence, although it's kind of one of those things that's always been out there, but people kind of find it hard to understand exactly how it did work. But certainly there's nice evidence out there that oral interferon alpha actually was beneficial in terms of improving the situation in inflammatory airway disease in a group of horses. So there's a randomized, this is kind of a graph from a randomized study there, showing that by day 8 here we had improvements in this case it was an endoscopic examination score in these horses with inflammatory airway disease. These were different dosages of the alpha interferon, and the interesting thing was that the slightly higher dose, you got a less beneficial effect than those doses down there kind of in the middle of kind of the slightly lower doses. There's also some evidence, just one paper actually, on the use of Xylexis in this particular type of problem, so airway disease in horses. So this inactivated pox virus, which as I say was on the market. So there was evidence in this study that there was reduced shedding of virus and bacteria and reduced clinical signs, or improved clinical signs rather, in this study they did, where they were subjecting them to equine herpes virus infection. So maybe there's some evidence there that some of these immunomodulators are beneficial. Here's another one as well. So it's a fairly recent study from 2015. Looking at polyunsaturated fatty acid, so omega-3 fatty acid. This was a random controlled trial, so quite a high level of confidence that this is a really nicely conducted trial, really. About 43 horses who had either REO or IED, but they pulled them together because they got a similar response in both these groups of horses. And these horses, they showed that, so these horses were in a low dose management and the plus or minus the polyunsaturated fatty acids, or placebo over these 2 months, and they found that all the horses on the treatments improved, but there was a greater improvement in the polyunsaturated fatty acids horses compared to those just on the low dose diet. So these are the curves. This is the curve for so this is the curve here for just management changes, and this is the curve for polyunsaturated fatty acids and management changes. So you see a more rapid improvement in clinical signs on that management regimen. So that's quite interesting findings, and maybe that needs to be kind of investigated slightly more. So I'll put a question mark there about stimulating the immune system. It's quite an interesting thing that we could potentially be doing. And then finally, just to kind of finish off really, these drugs to dissolve the mucus. I always thought this would be a really nice idea. It sounded really cool. And there was a drug available and still available actually. Maybe some of you use it in some cases still, sputilocin. And there was some evidence, early evidence when it was first brought on the market that it was potentially effective. But that's kind of not died a death, I suppose, but not many people use it nowadays. So that suggests to me that it probably isn't found that useful in more recent times. There are a variety of other types of options as well that we have. Acetylcysteine was looked at as well. IV saline heparin infusion, sound is used as well. There's kind of no good, really well-conducted evidence that these have a positive clinical effect. So I would say that there's probably not much evidence for the use of these things, unless anybody wants to disagree wholeheartedly with me on that particular thing. So there we are. I've got put a cross against the dissolving the mucus. Maybe you want to spend your money last on something like dissolving the mucus. So just to summarise there's good evidence that improving the environment helps. Anti-inflammatory medication as well, very good evidence. And then they maybe consider these other treatments based on individual circumstances, diagnosis, all these other things that I talked about at the start, until further evidence accumulates. So there we are. That's me. Thank you.